So welcome everybody this evening to our MS Academy webinar on the subject of MS fertility and pregnancy, which we're hoping to give you a multidisciplinary perspective on today. Thank you so much to our sponsor, Roche, who have kindly sponsored the webinar. They haven't had any input into the educational content of the webinar, but there will be a second session, which is a promotional satellite symposium. So with no further ado, just going to go through the timeline. So for the next 45 minutes, there'll be myself, Daisy Cam, and Parul Pinja talking about fertility, MS, and pregnancy. And then we've got the Roche Symposium after that. So just to introduce us all, my name's Kate Petheram. I'm a consultant neurologist working in Sunderland in the northeast of England, and I have a specialist interest in MS, but also in women's health surrounding MS. Daisy Cam is the lead MS specialist nurse in Sheffield, where she runs a specialty MS and pregnancy clinic, and she's going to tell us all about that. And I'm delighted to welcome a new speaker to the MS Academy, Parul Pinja, who's a consultant acute obstetric physician and in Birmingham. So the kind of aims and objectives today are there on the slide. We've broken this down so that Daisy's going to cover some of the common myths surrounding MS and pregnancy and talk a bit about her MS and pregnancy clinic in Sheffield. I'm going to mainly cover the DMT side of medications in pregnancy, and then Parallel some of the issues surrounding symptom management and perhaps symptom management and medications in pregnancy. And hopefully there'll be plenty of time for questions at the end. Just a quick plug for an upcoming Spasticity Academy webinar, which is a non-sponsored webinar on the 21st of October. So I'd encourage people to register for that. Use the Q&A function to ask questions during the sessions. We think we will mainly answer those towards the end. So without further ado, I'm going to pass over to Daisy, who's going to bust some myths surrounding MS and pregnancy for us. Thank you, Daisy.
Hello, everybody. Good evening. Thanks for joining. These are my disclosures. Next slide, Kate. Thanks. Lovely. So the common fears about pregnancy, as we all know, MS affects more women than men, and it's usually diagnosed in women within their childbearing age, which sometimes they haven't completed their family or even thought about having a family. So pregnancy really is a huge, important topic in the MS community. And for years and years, women were discouraged from having a family or even contemplating thinking about it. This luckily has changed over the years, but there are still a lot of common fears surrounding pregnancy in MS. These are actual quotes from patients that have said to us, people have told me having a baby can make your MS worse, which was the old-fashioned way of thinking. I'm scared about so many things, the drugs I'm taking, how my MS will be in the future, and whether I'll be able to even have children. Another one, my husband and I always planned to have children, but my MS has left me questioning if we should. Next slide, please, Kate. So a lot of the MS pregnancy myths, and they are myths, I'll go through them all later. So a lot of questions that we get are the MS drugs dangerous in pregnancy, which will be talked about with Kate later on. I won't be able to breastfeed. Is it harder to conceive with MS? I'll pass my MS on to my children. I will need to have extra scans. I will have to have a cesarean. Having a baby when you have MS is high risk. Next slide, please, Kate. So Rachel Horn is well known in the MS community. She has written a lot of papers on women and MS, particularly childbirth and pregnancy. And this is a quote from her. Andrea Shepherd, who has MS, was angry when an MS nurse told her not to have kids. Yes, there are challenges and support is key, but having MS doesn't mean you can't be a great parent or should be discouraged from this major life experience. I think the main thing in this quote is the support. The support is absolutely key for our ladies and gents who are thinking about starting or adding to their family. Next slide, please. So these are the myth busting slides. So having MS does not affect fertility. There's absolutely nothing out there to say that it can or it does. MS DMTs also do not affect fertility, regardless of how long you've been on them. It is very important, though, if you are planning a pregnancy, to discuss the drugs that you are on with your MS team, particularly regarding the DMTs you are on. Drugs for fertility also do not adversely affect MS. Next slide, please, Kate. You do not need to have a cesarean because you have MS. There may be medical reasons why cesarean is advised, but it should not be on the grounds of your diagnosis. Now it is a woman's choice to choose whether they have a cesarean or not. And in Sheffield, it is actually, understandably or not understandably, 50-50. So 50% of women in the general population choose now to have a cesarean, but you don't need to have one just because of your MS. You do not need extra growth scans because you have MS. Pregnancy with MS should be treated as a normal pregnancy, and unless there are medical indicators, there's no need for extra scans or extra tests. You also do not need to take blood thinners during pregnancy because you have MS, which is also a big myth, and a lot of our ladies have been advised to do this. Tommy's app is a really good resource for pregnancy and drugs and everything to do with pregnancy. So if you get a chance, I think this is a really good app to have a look at. Next slide, please, Kate. Lovely. So what is the risk of passing on MS to one's children? So the average lifetime risk of MS is less than 0.5%. So that's in 1 in 200 to 1 in 1,000. The risk for a child with a parent with MS is less than 2%. So that's 1 in 48. So there is a slightly higher chance, but really it's not a huge amount higher. So risk factors that can take this risk down is taking vitamin D and obviously not smoking. We know that smoking is a huge risk for MS. So we would always encourage any of our patients to stop smoking and take a vitamin D supplement. Next slide, please, Kate. Lovely. So what are the challenges of managing symptoms during pregnancy when you have MS? Which one is which? We know that there's so many of the symptoms of MS can overlap pregnancy symptoms, one of which is fatigue. So we know that fatigue is a huge issue in MS for a lot of people. And we also know that fatigue can increase in pregnancy, particularly in the first trimester and often in the last trimester as well. You can also have sleep disturbances with MS, and you can also have sleep disturbances in pregnancy. Again, particularly during the last trimester, this is due to being uncomfortable, having to go to the toilet more. So this can add to the fatigue that a patient may already have. Aches and pains in the joints can increase. Your mood can change due to the hormone fluctuations, again, particularly in the first trimester. But again, we know that mood can change with MS. There is a very low risk of relapses during pregnancy, which we'll discuss later. But if they do occur, they can be treated with steroids if needed. But it is best to avoid giving steroids in the first trimester. Having an MRI is not contraindicated during pregnancy, but gadolinium should be avoided if at all possible. We often get ladies coming to clinic who have been taken off a lot of their medications by their GPs. And if you find that this happens, it's really important to speak to the patient and seek advice from an obstetrician as to what is safe to take during pregnancy. Again, there's 2 more websites below. One is Bumps and one is LacMed, which talks about the drugs you can take during breastfeeding. Next slide, please, Kate. So this is just a very quick overview of what we set up here in Sheffield. We were finding we have a huge population of MS. The nurses' caseload is over 4,000 and we have over 3,000 patients on a disease-modifying therapy. So it was a really big subject, and there was a real need in the service, we felt, to address these women's problems. There's always been a lack of healthcare for women in general, but within our population, there was a real lack of joined up care for pregnancy and for women that were thinking about pregnancy. So myself and Dr. Ismail, who's very sadly left, but I think she might be listening in on this call, I'm not sure. We decided to get together and try and address this issue. So we asked one of the obstetrician consultants who has a specialist interest in maternal medicine, who has been running the epilepsy clinic for many years, if she would be interested. And luckily for us, she was. So what we decided to do was to set up 2 separate clinics. Firstly, a preconception clinic for women and men who were thinking about getting pregnant. And then we also decided to set up a very separate clinic for pregnant ladies. So the preconception clinic, sorry, Kate, sorry, would you mind just going back one slide? Sorry. So this is just the pathway that we put together. So a patient informs their MS team or their GP that they're planning to become pregnant or that they are pregnant. So if you follow the pathway down, so they would be referred to one of the clinics, whether it's preconception if they're thinking about it or if they were already pregnant. So we would see them in clinic and advise them to start folic acid and vitamin D. We would also link up with the maternal medicines team, and then if they had any MS-related issues, they would come back to the MS nurses. Any pregnancy-related issues, they would come to they would seek the advice of their midwife. So once they successfully delivered, we would see them postpartum and make sure that their MS plan and treatments were back in place, and then they would be discharged back to their original MS consultant. Next slide, please, Kate. So the preconception clinic is run every 3 months. Patients can self-refer or they can be referred by their consultant, MS nurse, or their GP. A medication obstetric history is taken at that clinic. Advice is given regarding safe MS medication options in pregnancy, and we also give advice on optimizing health, their general health prior to pregnancy. So far, we've seen 78 patients in this clinic, and it's run with myself, one of the consultant neurologists, and a specialist midwife who joins us in those clinics. Next slide, please, Kate. So the pregnancy clinic is run every month. This is run by myself, a consultant neurologist, and Tessa Bonnet, who is the consultant obstetrician, one of the consultant obstetricians here in Sheffield. So we see the patients in their 1st and 3rd trimester, and then once again postnatally. It's great because it's joined up cross-speciality working. We go over to the maternal hospital, which is next door to ours, and we do the clinic all in one room. So patients are a bit overwhelmed when they walk in and there's loads of us there, but it means that they're not having loads and loads of different appointments with different services. We've managed 75 pregnancies through this service. Women feel very well supported, and it was the first MS obstetric antenatal clinic in the UK with a nurse, an MS nurse, an MS consultant, and a consultant obstetrician all in the same room together. We've had great feedback, haven't got time to go through it, but we've had really good feedback from patients, and saying particularly the patients who've had a baby before these clinics were set up, compared to having a baby and coming through this clinic, they feel that the support really wasn't there before, but it is now. And I do appreciate that everywhere is very different around the UK, and not everybody can even start to think about setting up clinics like this, but they have been a real success, and they're my favorite clinics of the month, so it's been great. Next slide, please, Kate. So that's my bit over and done with. It was short and sweet, but I'm very happy to answer any questions at the end if we have time. I'll hand you over to Kate for her session on DMTs and MS and pregnancy.
Thank you so much, Daisy. That was fantastic. And it is a bit of a whistle-stop tour, so we'll welcome questions at the end and any conversations that people want to have. So these are my disclosures, none of which are relevant to today's talk. So I think the important thing that we're talking about this, and there are lots of webinars, lots of interest in this, because there's still a therapeutic inertia in women with MS. So this is just highlighting an analysis, some research that was presented last year at ECTRIMS, of analysis of over 22,000 patients in a French register, of which 3/4 were women, and researchers found that women still have a significantly lower probability of being treated with any DMT, and were even less likely to be prescribed high efficacy DMTs. So it's really important that we're having these conversations and make sure that we overcome this therapeutic inertia. As Daisy said, DMT decisions are really complex anyway, but I would argue that we should be having a conversation about family planning in any patient, but particularly women of childbearing age. And I would take that from teenagers right through to anybody in their mid to late 40s, 50s, because you just don't know. And so it needs to be talked about. So one of the questions that people want to know regarding MS and pregnancy is, is pregnancy going to affect MS activity? And most of us in the MS and neurology world are familiar with the Comparvue graph, which demonstrates that during pregnancy, there is a drop-off in annualized relapse rates, and you're much less likely to have relapses during pregnancy. But then postpartum, there's this apparent risk, increased risk of relapses postpartum. And this kind of shape of the graph still seems to hold true even in a more modern cohort of patients who will have been treated, more likely to have been treated with disease-modifying therapies prior to pregnancy. So you can see that on the right hand, the graph, and we are seeing a flattening, so less relapses prior to pregnancy, still slightly less through pregnancy, but still this kind of, on the whole, this jump postpartum. And really that's kind of what we want to be trying to avoid as well. So other research has been done in terms to, how do we reduce postpartum relapses? And there's lots of research going on to risk factors for postpartum relapses. So what makes you more likely to relapse and what's going to make you less likely to relapse? And a lot of it's about what you would expect. So disease activity. So how active is someone's MS? Anyway, so if you've got an increased risk of relapse rate pre-pregnancy, you're more likely to relapse postpartum. If you relapse during pregnancy, that's a definite risk factor. And if you're more disabled prior to pregnancy onset. The protective factors are breastfeeding, although it won't completely protect you. It's partly protective, and perhaps logically a more stable and optimized disease pre-pregnancy. So it's becoming more and more apparent that DMT choice preconception matters. And I think this recent publication from last year demonstrates, was a study of about I think it was 66 pregnancies of people on high efficacy treatment. And I think what's quite striking is the red line at the bottom, and that patients who are on an anti-CD20 medication preconception not only had very few pregnancy relapses, but had very few postpartum relapses. And perhaps this will be talked about a bit in the symposium. When we're thinking about kind of drugs in any kind of drug, but particularly immunomodulatory drugs in pregnancy, there are 3 different approaches to this. And one option would be to follow the label, to follow the standard guidance and the manufacturer's recommendation. And the challenge to this is that there's kind of wide variations between even which country that the drug is licensed in, and the kind of drugs with the same mode of action. So different anti-CD20s have different advice. So it doesn't seem to be totally logical. The other option is just to wait for the drug to be cleared from the body. So exponential decay, waiting for 5 maximal half-lives. That ensures most of the drug's gone, but the challenges for that are drugs like teriflunomide, where you've got a very long elimination rate, or drugs where we are worried about relapse. So the S1P modulators, particularly fingolimod and natalizumab, we're obviously concerned that if we leave that off for a long period of time, then the patient has significant risk of relapses. The other option is to do, I think what we're doing more increasingly in the MS world, is to use real world evidence and weigh the risks and benefits for the patient and the fetus. And this is evolving case by case. And there's an increasing number of guidance to help us do this. We don't have to be making these decisions completely on our own. And I've highlighted there 3, I think, important publications. Important to note that the UK consensus on pregnancy and MS, the ABN guidelines, is being updated soon, and I think are expected to be published at the end of this year. One of the most useful things that I find to give to patients in clinic is a leaflet produced by the MS Pregnancy Register Group, which summarises those UK ABN consensus guidelines. And these are also available on a new website, pregnancy.ms, which I would recommend everybody have a look at. That brings together the up-to-date guidelines and any research that's going on into MS and pregnancy for patients. So that's useful for both clinicians and for patients. So I'm just going to do a very quick whistle stop. I'm aware of timing, and I want to give plenty of time to the symptomatic management of MS in pregnancy as well. But so disease-modifying therapies that we're comfortable in continuing through pregnancy, and that includes the interferons of glutathione acetate. So if a patient was taking these prior to pregnancy, and many patients historically have chosen to go on these drugs before we became more comfortable with others, have chosen these because of pregnancy. So we would continue these through pregnancy. Natalizumab, I think for at least, I think I had my, well, not personally, but looked after my first natalizumab baby is now, I think, 10 years old. So increasingly now we're continuing natalizumab throughout pregnancy, and the license now allows us to do that. We extend interval throughout pregnancy, and I would recommend the last dose is given at or before 34 weeks of pregnancy. And if you do that, there's no need to really check for blood dyscrasias in the neonate. None of these drugs are drugs that I would recommend continuing through pregnancy, and would recommend stopping before trying to conceive. So I would avoid S1P inhibitors generally in patients planning a pregnancy in the next few years. As we know from real life, that doesn't always happen. So I have had patients on a fingolimod who have wanted to have, start a family because historically they may have been started at 10 years ago when there wasn't much other option if they had highly active disease. So other oral treatments, teriflunomide, where I think we're all familiar with the fact that this has been shown to be harmful in animal studies. You would want to stop 2 years before trying to conceive or undergo accelerated washout, and it's not recommended in breastfeeding. There isn't a lot of human data on this, probably because hopefully we're quite good at preventing patients. And if a patient became pregnant, you would perform the accelerated elimination procedure. Dimethyl fumarate, there's been no real association with adverse events in pregnancy, but it's generally not recommended to continue through pregnancy. A couple of options if you have someone on DMF who's wanting to conceive, you may consider a direct switch to an injectable to be continued through pregnancy. Conservative management would be a 2-week washout, or alternatively to continue until the point of conception. Induction therapies are a really good option for women planning pregnancy impact in the next few years. And this was where we used to use alemtuzumab a lot before its license was restricted, and can now be only used for res MS. But with cladribine, one would advise male and female patients shouldn't get pregnant for 6 months after the last dose, and for alemtuzumab 4 months after the last dose. Sorry, gone a bit fast. The anti-CD20s, oclizumab, I would generally recommend stopping conception 1 to 3 months before after the last dose. We're going to hear more about this, I think, in the symposium. I would redose if not pregnant by 6 to 9 months, and restart soon after birth. And by soon, I mean 2 to 4 weeks after birth. Ofatumumab, similar. I would have a cautious approach, would be to stop for 3 months prior to trying to conceive. But alternatively, I tend to be quite comfortable telling patients so they can continue it until the point of conception, until they're pregnant. Alternatively, what we do if someone's been on ofatumumab for a while and is planning a pregnancy, given that oclizumab is perceivably going to have a longer kind of mode of action, we might offer women planning a pregnancy a dose of oclizumab to kind of carry them through that pregnancy. And these kind of changes in the anti-CD20s are based on real world data, which we're going to hear a little bit more about, I'm sure. And the Minore study, largest data subset of reported pregnancies on anti-CD20s in MS, which showed that wasn't associated with an increased risk of adverse events. And just very quickly about disease-modifying therapies and breastfeeding. I've summarized this very succinctly, but injectables, large molecules, not going to generally get into breast milk, and if they're not going to be available orally. So we can be very happy with people continuing interferon and glutamate through pregnancy. Don't generally recommend continuing orals with breastfeeding. And again, all the monoclonals are large molecules which are inactive when orally absorbed. This is, I think, a really interesting study. There is on LactMed information about the relative infant dose in breast milk. And then also it's important to consider the oral bioavailability. So as I previously mentioned. And again, we'll hear about the Sopranino study, which looked at the ocrelizumab levels in breast milk and found they were undetectable in infant serum. And I think this is a really important study because it led to a label change for ocrelizumab, and which has opened up the options for women. Just a quick plug for the pregnancy register. So any women that you have that are pregnant and have MS should be encouraged to register themselves for the MS pregnancy register so we can get all the information possible to enable us to give future women the best information and advice. So hopefully I've given enough time to deal with some other very important issues with pregnancy and MS. So I'm going to hand over to Parol now.
Thanks, Kate, and thank you for the invitation to speak today. Next slide, please. My disclosures. Next slide. So there are some guidelines, and both my colleagues have sort of pointed to them, and you'd be pleased to know that there should be an update coming shortly. But I think we're all singing off the same hymn sheet when we sort of discuss the importance of pre-pregnancy counselling, and I'm really pleased to hear the work that's going on in Sheffield. Again, just to reiterate, you're not an automatically high-risk pregnancy if you have multiple sclerosis, and you can receive steroids in pregnancy. Vitamin D is really, really important, and we would be very supportive of breastfeeding in most cases. Next slide, please. So we've touched on this before, but I think it's really important with more and more women looking at assisted conception techniques. We know that MS doesn't directly affect fertility, nor do the fertility drugs used in most assisted conception techniques affect MS. There's no increased risk of prematurity, growth restriction, or any other adverse obstetric outcome. However, women may have a delay to conception due to MS symptoms such as sexual dysfunction, fatigue, or any other psychological issue. So it's really important to ask women this at every appointment and talk about things like sexual dysfunction. DMTs do not affect ovarian reserve or male fertility, and it's important that we don't delay referral to fertility services if no conception occurs within a year. And that women themselves may not volunteer that information, and they perhaps have been trying for a longer period of time. So it's important that we ask those questions and signpost women to fertility services. Next slide, please. We've talked about mental health, and so it's really, really important. Sadly, the leading cause of maternal mortality in the postnatal period in the UK is suicide. This is harrowing, and it's really, really important that we ask at every encounter the state of a woman's mental health and signpost them to perinatal mental health services, or suggest they address their mental health potentially with medication. Just to note, antidepressants such as SSRIs, SNRIs, and tricyclics, and sometimes we use tricyclics for pain, you can use in pregnancy. And with any medication in pregnancy or any therapy, we look at the risk, the perceived risk, often if there is a lack of evidence, versus the intended benefit. With antidepressants, there's no association with miscarriage, preterm delivery, or low birth weight. Historically, there have been concerns around a slight increased risk of persistent pulmonary hypertension of the newborn. Baseline is around 2 in 1,000 births, and this has increased to 3 in 1,000 births with antidepressants. However, it's unclear whether that's a true drug effect or due to multiple other confounders. We also must ask about smoking, drugs, and alcohol, as we would do with any woman. Next slide, please. What about my other medical problems? This is a question that's frequently asked about women, asked by women. And this just sums up the importance of holistic care and keeping an open mind around alternative diagnosis. I frequently in my obstetric medicine clinic see women not just with MS, but they may well have asthma, inflammatory bowel disease, or a whole host of other comorbidities. And we just need to keep an open mind to ensure that we're addressing all of those, as well as then ascertaining what the risk, maternal risk and obstetric risk is due to those other comorbidities. Sadly, we know due to our own cognitive biases that once a label is put on a patient that they have a condition like MS, the risk we run is that every symptom is attributed to that, whether that's truly the case or not. So it just goes back to understanding that disease in that woman and seeing, well, actually, is this MS or could there be something else going on? Medical problems in pregnancy are, thank you, medical problems in pregnancy sadly are on the increase, and vague symptoms can be an early presentation of other medical problems. So think about what red flag signs and symptoms can occur in these cases. Multiple sclerosis itself shouldn't affect other comorbidities, but don't forget other comorbidities and potentially the impact they may well have on MS. Next slide, please. How is MS going to affect my pregnancy? Well, I think we've spoken about this a little bit. Most women find that their symptoms settle during pregnancy and the risk of flare tends to reduce. That risk of flare is highest in the postpartum period, and we think that breastfeeding can actually help. But there are some symptoms that may get worse. There is an increased risk of UTI in pregnancy. Due to hormonal reasons, gastric transit it slows down in pregnancy. So symptoms such as gastroesophageal reflux presenting as chest pain or nausea can worsen, and constipation can certainly worsen, which can lead to abdominal pain and back pain. So sometimes differentiating between those symptoms and symptoms of MS may well be problematic. For hormonal reasons, relaxin increases in pregnancy, and ligaments and joints can all relax as the pelvis and back widen to accommodate for delivery. So women can suffer with back pain, sciatica, and typically symphysis pubic dysfunction. That can be very debilitating and it can reduce mobility. That in itself can increase the risk of VTE. So we talked before, Daisy talked before, that having MS doesn't increase your risk of VTE. However, if your MS or any other condition or pregnancy itself does cause a reduction in mobility, that can increase the risk of venous thromboembolism. Venous thromboembolism, sadly, is the leading cause of maternal mortality currently. So at every obstetric appointment, a woman is assessed for her venous thromboembolism risk, and that is then acted upon. And she may well need prophylactic low molecular weight heparin. So it's really important, if you see a woman in your neurology clinic and she's flared and has got a reduction in mobility, we need to liaise with obstetrics because she may well have an elevated VTE risk, which necessitates either low molecular weight heparin straight away or perhaps at 28 weeks onwards. MS doesn't increase the risk of preeclampsia, nor does it increase the risk of obstetric hemorrhage. Next slide, please. So medication, Kate's spoken wonderfully about the DMT, so I'm not going to speak about them, but frequently I see women that are on a whole host of medication for their symptoms and listed below, so I'll talk a little bit about that in pregnancy. Next slide, please. So headlines like this really don't help when you're trying to get women on board when it comes to medication in pregnancy. It is safe to assume that even with robust pre-pregnancy counselling, women will stop taking medication. They will assume that medication will harm their baby, even if they've been told that it won't. And sadly, sometimes well-meaning people will advise them to say, well, you sure you should be taking that? Or they read the packet, the information leaflet in the packet, and sadly, it can cause harm. It says, do not use in pregnancy. So despite our advice, women stop. So next slide, please. So we really have to sort of unpick some of these headlines. This came from a Nature article, and it's a narrative, not an RCT. It's a consensus statement without specialty input. And the comments were on neurodiversity, neurodevelopmental delay, and neurocongenital abnormalities in boys, but there were multiple confounders. Recall bias and the use of paracetamol or other medication in infants was not explored. So this is very, very flawed, and we really need to reassure women that simple analgesia, you know, the smallest dose for the shortest period of time is the best thing to do. And that's just good advice for anyone, really. And certainly women who take paracetamol can breastfeed. Next slide, please. Non-steroidals you can use until the end of the second trimester and in breastfeeding mothers. After this, it can cause premature closure of the patent ductus arteriosus in the fetus. So we would only use them for the first 2 trimesters. Again, the lowest possible dose for the shortest period of time. Long-term use of non-steroidals can lead to hypertension and renal dysfunction. Opioids. Now, with morphine, there is a risk of neonatal withdrawal and respiratory depression if used around delivery. So any woman on any form of opioid should have a neonatal alert so that the team are aware that when baby is born, they can be monitored. With codeine and dihydrocodeine, again, I would only use if I absolutely had to, because this medication is problematic with its side effect profile. It can worsen nausea and vomiting, it can worsen constipation, and it can cause overuse headaches. With codeine and dihydrocodeine, prolonged use in pregnancy can lead to detectable levels in breast milk. But dihydrocodeine's metabolism is slightly more predictable, so that is the option for use in breastfeeding. Codeine itself is contraindicated, but again, breastfeeding infants should be monitored for the first few days. Next slide, please. Baclofen. There is very limited data about baclofen in pregnancy and breastfeeding. There's a small cohort study, a few case series, and a few case reports. There's a slight increased risk of congenital malformations, but there's no pattern of defects, and it's unclear whether this is statistically significant given the small numbers. There is insufficient data with regards to the risk of intrauterine death, low birth weight, or preterm delivery. And again, there are multiple here. So my practice is, what is the risk versus the benefit of continuing? Is there a possibility that we can reduce the dose? Possibly avoid it in the first trimester, which is when organogenesis occurs. So this is where pre-pregnancy counselling is really important. And I sometimes come to an agreement with a woman about what we would want to do in the first trimester. And then I see them quite frequently in the early pregnancy to see how we're getting on and can we avoid it, or do we need to restart it? Again, a neonatal alert because of the lack of data. Women can breastfeed. Small levels of baclofen, the levels are low in breast milk, so women can breastfeed. Next slide, please. With pregabalin, there's a small increased risk of malformations, but again, the data is limited and there are multiple confounders because most of the data comes from women with epilepsy. There is conflicting evidence that there might be a slight increase in major congenital malformations, but there's no conclusive evidence here, really. And there's no effect on maternal folate status. However, for women with epilepsy, UK guidance states taking 5 milligrams of folic acid. So again, I would use this at the lowest possible dose and try and avoid it in the first trimester if I can. Women need a neonatal alert, but actually safe in breastfeeding. And the advice for gabapentin is much the same. Very little data. Women can breastfeed. And what I tend to do, again, is outline the lack of data to the woman birthing person, and we come to some sort of shared decision making. Antibiotics. Avoid trimethoprim in the first trimester and tetracycline, doxycycline after 20 weeks. Quinolones are all contraindicated, but penicillins, cephalosporins are probably your choice for treating UTIs. Macrolides you can also use. Next slide, please. Am I a high-risk pregnancy? And that's something women really do worry about, and not necessarily. The risk is dictated by the degree of debilitation and obstetric risk factors. And as Daisy mentioned, there's no indication for extra scans or appointments unless there are obstetric indications or other comorbidities or medication that necessitate this. Some women will require consultant-led care and an anaesthetic review if they've got complex disease. And my plea really is that to our neurology colleagues is if a woman has residual neurological impairment, it's really useful if that is documented prior to entering into a pregnancy, because it really helps our anaesthetic colleagues when it comes to planning neuroaxial anaesthesia. Next slide, please. Do I need a cesarean section? I think we've spoken about this. This is not dictated by multiple sclerosis. And even women with significant debilitation who perhaps feel their movement and mobility is limited may well be able to have a vaginal delivery. And we've got specialist midwives that can see them before delivery to assess what positions they can get into and for how long. for their vaginal delivery. The risks of cesarean section include UTI, VTE, infection, and delayed wound healing. So it is not a benign procedure. Do they have a higher risk of obstetric complications? Certainly not because of MS. It would be dictated by other things, including physical debilitation. Next slide. What about my next pregnancy? Well, the risk of flare is highest postpartum, and that future landscape may look different. So whilst they may have had pre-pregnancy counselling and advice that was bespoke to this pregnancy, the next pregnancy may look different. So it's important that we start that future pregnancy planning in the postpartum period and ensure that a woman is on contraception to allow her next pregnancy to be planned. These are useful resources. I think Daisy mentioned UKTIS. BUMP's best use of medicines in pregnancy is the patient-facing element. LactMed for breastfeeding is great, as is the UK Drugs in Lactation Service Advisory Service, UK DILAS. Thank you.
Thank you so much, Pal. That was fantastic. And it really has been a whistle-stop tour, I think, for all of us. I think we'd all love to have had twice as much time to talk about what we were given to talk about. I'm told we've probably got 30 seconds to a minute for questions and answers. So not very long. There's perhaps 2 questions I thought we could possibly take really quickly. One was about dose of vitamin D3 recommended. Daisy, I would probably just recommend people continue to take the 4,000 units that I recommend for all my patients. Would you do anything differently?
No, that's exactly what we recommend. I know that some centres are recommending more, but at the moment, I think there isn't enough data, so we just stick by what they're on. But it does amaze me how many ladies of our patients are not already on vitamin D. So we stress that they need to stay on it post pregnancy as well.
And I think Alison has asked about a template of areas that you explore during your conception consultation. So I'm sure that's something that you would be more than happy to share.
Yeah, absolutely, not a problem.
You can contact Daisy or any of us through the MS Academy for more information about any of these things. So thank you so much to everybody for joining. I hope it's been useful. I hope it's been interesting. Thank you so much to Daisy, and thank you to Parol. It's been an absolute pleasure. I hope we can do something again in the future.
Thank you, Kate. Thank you, everybody. Thanks for joining.